Okay, we're going to start with our afternoon session, and just to welcome you back from your lunch. I hope you've all enjoyed the morning and have been given plenty of food for thought in terms of all of the work that's going on elsewhere, and I suppose thinking about what needs to happen here in Ireland. I think as the National Director for Mental Health, I have a real interest in seeing how we can integrate services. We've come from a history where mental health has been quite separate in many respects, and really across all different services, divisions, etc., we really need to look at how we can integrate to really meet the needs of the population to whom we provide services. So I'm going to kick off the session now by introducing Dr. Jennifer Williams. Dr. Williams is an epilepsy research fellow at St James's Hospital and the Academic Centre for Neurology in Trinity College. And she's going to talk to us about a preliminary study of an implemented integrated care pathway for the management of seizure ED presentations at St James's Hospital. So I'll hand you over to Dr. Williams. And if I could just ask all speakers, maybe just in terms of watching time, because we've quite a number of speakers this afternoon, and also for those of you in the audience who haven't completed an evaluation form, if you could please do so, because that allows us then to think about how the day has gone and to use that for future events. So if you wouldn't mind filling that in and leaving it when you're going. Thanks very much.
So good afternoon. As said there, I'm Jennifer Williams. I work as an epilepsy fellow in St James's Hospital. I'm delighted to present some of our preliminary data on how we deal with seizures in the emergency department. Epilepsy is the second most chronic neurological condition, second only to stroke in Ireland. 37,000 people with epilepsy. There are 37,000 people with epilepsy in Ireland, 40,000 if you count for those under 5. This gives us a point prevalence of 0.8 to 0.9%, which is in line with other industrialised nations. It's a complex condition with a lot of comorbidities and social and financial burden. A study carried out back in 2007 estimated that the financial burden was 15 billion, which equals the combined financial burden of breast and lung cancer. Up to 30% of people with epilepsy have poorly controlled disease. This prompts presentations to the emergency departments where care with non-specialists can be variable and not evidence-based. In 2010, prior to the establishment of the National Epilepsy Programme, there was a vision that we should try and provide the best value of care for all people with epilepsy in the right place, at the right time, and sharing the best available information. There were 3 overriding aims: quality, access, and value. Each of those headings has 3 subheadings, but I'm just here today to talk about one of those, and that's care in the emergency department with an integrated care pathway. Work from our group has previously shown, back in 2012, that an integrated care pathway, which is an evidence-based map of a journey a patient should have from presentation to the ED up to the decision to admit or discharge that patient, showed that when we looked at the admissions from November 2006 to 2007, if a pathway was applied, the admission rate could be reduced by 36%, as could the median length of stay, and representations to the emergency department could be reduced as well. We know from data back from the NASH study that was published in 2011, which was the largest epilepsy audit which took place in the UK, over 127 hospitals, over 3,700 patients. And it looked at the first 30 presentations with seizures to the emergency department and evaluated them over multiple care metrics, such as a good eyewitness account, were they counselled about driving, were they examined properly, and was that examination documented? What they found was that there was a wide variability in care, there was no consistency, and it varied very much whether people were referred on to specialist services. And what was most worrying was they had an awful lot of low discussion of documentation around driving, which is a legal requirement. With this in mind, the National Epilepsy Programme, under the guidance of Dr. Colin Doherty as the National Clinical Lead, developed an integrated care pathway for seizures for use in the emergency department. The aims of the pathway were to use evidence-based medicine to guide the patient journey through the emergency department, to give the emergency department physicians tools on what assessments and treatments should happen or for a patient with seizures who present, to reduce unnecessary hospital admissions, and to provide a patient-centred care journey. Incorporated into the pathway are the AAN guidelines and NICE guidelines for quality and standards of care. So this is the first page, and that's what it looks like. How it's supposed to work in practice is the triage nurses or ED docs fill out the integrated care pathway. They examine the patient, evaluate the patient, decide whether the patient, via the Decision 3, requires discharge versus admission. If the patient is for discharge, there's a patient information leaflet on the back of the pathway which tells the patient when they're going to be contacted by our advanced nurse practitioners. The pathway is then, with the patient's contact details and all the clinical information that's relevant, is put into the ANP referrals box, and within 10 days the advanced nurse practitioners call the patients and give them a rapid access clinic appointment within 6 weeks of emergency department presentation. If the patient needs to be admitted, the integrated care pathway is given to the medical team as a form of referral, is placed in the patient's admission notes, and is part of the treatment plan. It's therefore then part of the patient's paper record. So when a seizure arrives, either the patient has established epilepsy or recurrent seizures or first seizures, the process is that the ICP is retrieved from the nurse's station. Then the physician or clinician gets an eyewitness account. We have certain measures such as non-convulsive seizure, single self-limiting seizure, or if a patient is awake, alert and fully neurologically normal at 90 minutes with a normal CT brain or exam, we were to consider discharge, place the ICP in the ANP box and give the patient the advice leaflet. If, for instance, the patient isn't suitable for discharge, the epilepsy pathway then takes the physician down the route of we have to consider acute treatment of the underlying cause, refer the patient for admission, or consider status epilepticus. So this is the second and third page of the pathway. You can see on the left-hand side of your screen there is a time scale from T0 to T60 minutes, which is basically what should happen to a patient when they arrive at the emergency department. It goes through the standards of care, what the minimum that a patient should have, all the blood workup, all the imaging workup as necessary, etc. It also goes through what information the emergency department physicians need to obtain in order to make those decisions. And incorporated into this pathway are the NICE guidelines. So this is an evidence-based pathway of care. The integrated care pathway also has the NASH measures, which were audited by the UK group in our pathway, which includes neurological examination, certain standard metrics such as temperature, glucose, etc., and ECG with calculation of the QTC interval. There's also an appendix at the back which guides clinicians. There's 8 reasons why you might consider admission for a patient. And obviously there's the signature, etc. at the back for the clinicians. Possibly the most important bit of the pathway is actually the bit that we give the patients for if they are discharged. So this is an information leaflet giving them the contact details of the specialist nurse advice line, explaining to them what will happen and what their care journey is going to be, so that they should receive a call within the 10 days, that they can contact the service via email or via telephone should they have a problem in the meantime, explaining to them that they will then be booked into a clinic and the investigations as necessary. In the last page, there's a further information for clinicians as to consider the medical causes of a seizure, and also certain red flags that might prompt the clinicians to consider more serious seizures. So what we decided to do is this integrated care pathway has been run in St James's emergency department for the last few years, and we decided that we'd like to see how we were getting on with it and was it being used. So we wanted to audit the percentage of seizure presentations to the emergency department that got the pathway, compare the standards of care between those who got the pathway and those that didn't, to evaluate the adherence to the ICP, and report back the findings to the emergency department and identify areas for improvement. So we undertook this audit from September of last year to June of this year. We examined triage list for all those days, which was no short task. We identified 456 patients who presented with a seizure, epilepsy or fit as the primary diagnosis given by the triage nurse. All patients in our institution, their ED notes are scanned onto the hospital computer system, and we reviewed those notes to see were they actually physically put on the pathway or were they just given the normal ED notes. So we found that the average age of presentation was 42 years. 20% had documented that this was their first seizure. 66% of those that presented had prior seizures, and 45 of the total 456 had confirmed epilepsy. But 14% there was no documentation as to whether this was their first seizure or not. Importantly, and perhaps somewhat disappointingly, only 26, so nearly just 1 in 3, were put on the integrated care pathway, and we'll talk about possible reasons for that later. So in total, 28.7% of those on the integrated care pathway were admitted, whereas 45.9% of those not on the pathway were. But what really struck a chord with me as a clinician, particularly as a neurology specialist, is that only 1 in 3 people who presented with a seizure who didn't get the pathway got a neurological exam, whereas 90% of those on the pathway did. And those mirror the other metrics there, such as fundi implanters, which are all part of a comprehensive neurological exam. Also, only 1 in 2 patients who got the pathway had driving documentation, but none who weren't on the pathway did. And that's a legal requirement. The standout figure really is the readmission with a seizure, or we should say representation with a seizure. 0.8% of those who got the integrated care pathway, i.e. would be given to, their details would be given to the advanced nurse practitioners, they would be phoned within 10 days and they would get the rapid access clinic appointment. Only 0.8% represented to the emergency department, but nearly 10 times that represented if they didn't get the pathway. So what have we learned from this study? Patients that were on the ICP got better standards of care documented, but those not on the ICP were 10 times more likely to represent within the following months. The legal implications were only documented in half of the ICP patients and none of the non-ICP patients, and only 1 in 3 were placed on the pathway if they presented to the ED. So we did a little calculation. There is potential savings here. Approximately 6,000, according to HYPE data, 6,000 patients are admitted with a seizure every year. That 1 in 3 that present are admitted, so there's approximately 18,000 presentations with a seizure. And a visit, just a visit, costs €268. That's before you go into admission, investigation overnight, just the presentation with a seizure to the emergency department. And if we put everyone on the care pathway, those that represented that weren't on the pathway, there was a potential saving of nearly €300,000. So where do we need to go from here? We obviously, there's a lot, some done, we need a lot more, we have to do a lot more. In the coming year, we plan through the DICE study to employ a facilitator for 1 year to address why the ICP isn't being used, to address the human factors in the emergency department that are causing it to only be used in 1 in 3 people. Should it be electronic versus paper? One of the big factors is the rotation of junior doctors through the emergency department. So if you're on a medical scheme or a surgical scheme, you rotate every 3 months, and if you're on a GP scheme, you rotate every 4 months. So we need to have regular in-service training on how to use these pathways for doctors and audit them on a monthly basis and feed back to them areas for improvement and perhaps change the pathways to make it more useful for them. We also need to engage with ANPs in the emergency department and triage nurses so that when a patient with a seizure comes to the emergency department, the pathway is clipped to their triage note, so that the doctor doesn't have to think about it or go looking for it. So to have it in the triage room, and perhaps use incentives for use. So that's just at a local level. Nationally, I think we need to perform the NASH audit on the 10 neurology hospitals. And as part of the eBase programme, St James's and Beaumont and UCD are collaborating on a European study to look at the burden of care of epilepsy. At the moment, I think one of my colleagues is undertaking a systematic review of guidelines for epilepsy care. And through all this work, we should create a national guideline through the National Clinical Effectiveness Committee. So the take-home message really from this talk is there's obviously a variability in care in patients presenting to the ED with seizures. Those on the ICP get better care. We need to reduce representation rates by using the ICP for potential improvements. But this involves engagement and management with our colleagues, both in the ED and across the ANPs. Thank you very much.
Thanks, Jennifer. It's interesting to see in terms of the take-home messages the need for ongoing system improvement, that it's not something that obviously you can just set up and walk away from after a few months, and the need to continually engage and review. Also in terms of reducing presentations to the ED, and that leads us in nicely to our next speaker, Noreen Curtin, who is the Programme Manager for the Community Intervention Team and OPAT Programme. And I suppose as an initiative, this is a key example in terms of something that can work very well in terms of keeping people away from acute services or getting them out of acute services more quickly. Noreen has been seconded to this post from her previous role, or her substantive role, as a physiotherapy manager in Tala. So I'd like you to welcome Noreen now, who's going to talk through her programme. Thanks very much.
That's great. Thanks very much, and for the opportunity to speak this afternoon about the community intervention team. So what I'd like to go through is the role and purpose of the CIT, and to take you through some case studies which I think well describe the service that it provides. So looking first of all at the community intervention team, so it's a nurse-led service, and it's providing an intervention for a patient with an acute episode of illness, and typically a defined short period of time. So typically that would be less than 72 hours. So you'll have some patients who will complete their care with the CIT team, and for others it'll be necessary that after that time period they might be their care transferred on to the public health nurse or other services that are available in the community. So again, the range of services, the first to mention is as regards home IV antibiotics and OPAT. So OPAT is one of the clinical care programmes, and traditionally patients on IV antibiotics remained in hospital. They stayed as an inpatient for the duration of the course of antibiotics. And what the OPAT programme is looking to do is that people on IV antibiotics can have their IV antibiotics at home. So it's very much a collaboration between primary care and the executive lead, Brian Murphy, and Dr. Susie Clark as the national clinic lead for OPAT. And with the support of the programmes, having those national standards in place so that you're both identifying appropriate patients, that there's a pathway for the referral, and then that there aren't appropriate antibiotics. Or for others, it's actually in that they're switched orals or their antibiotics are stopped. A range of other services. The programme, the CIT service is accessible from 8 a.m. till 10 p.m. 7 days a week. So there's a number of nursing services that the referral might be in and out of hours, so it might be an evening or a weekend, and there's a range of services here that they provide. These are the location of the services at the moment. So there's 10 CIT teams. The green and Clare and Tipperary, just to explain, they're in yellow, as we've a service in those counties, but it doesn't stretch out to the boundaries. So that's something that we're working on as a rollout plan, and also looking that in 2016 to roll out into further areas. And as part of that, we have the governance structure is we have an oversight group where we've representation from each of the community healthcare organisations. We've representation from nursing, from acute services, and from social care. Looking at numbers, there's about 200 patients, approximately 200 patients that are on the CIT OPAT programme at any one day. So that translates as about 360 to 400 referrals a week. And that's up on last year. So we're about 25% up on the same period last year, which is a combination of the existing services that their activity has increased, and also there's a number of new services that have been established in the last year. The CIT teams in the last year, we meet approximately every 2 months, and it's an opportunity for people to get together and build the networks, share protocols. We've introduced a standard referral, and at one of the workshops, each CIT team shared a case study, and I thought it was useful. I'm borrowing 2 of the case studies because I think it describes well the service it provides to patients. So this case study is a young man with quadriplegia after an accident, living at home with his parents, and has support from home support from disabilities. He developed a pressure ulcer which deteriorated, and he needed to be admitted to hospital. I was in hospital for 6 weeks on IV antibiotics. When his condition stabilised, it wasn't possible for him to return home on IV antibiotics because he still had a lot of nursing needs, and particularly at night. So he was transferred to a community nursing unit, and the referral was made to the CIT team for the IV antibiotics, and his home support was transferred to the community nursing unit. So it meant it was his home carers who were looking after him while he was there. So he was seen daily by the CIT team, where they would have administered the IV antibiotics, and they would have taken weekly bloods and looked after the line. Now, I mentioned as part of the OPAT programme there's national standards, and one of which would be that patients are reviewed weekly in clinic. Now, for this man, it would have been very difficult for him to attend a clinic because it would have been an ambulance transfer. So it was agreed that the CIT nurse took a photograph of the wound, and this was transferred and reviewed by the tissue viability nurse and the infectious disease consultant. So between monitoring the wound and also from a review of the bloods, they were able to monitor his care and make sure that he was responding. The nursing staff in the community nursing unit carried out nursing duties. His own carers were involved in care such as peg feeding, and again it was very much a number of people that were involved in his care in that time. So from an outcome, he required further 9 weeks of antibiotics, and after that time he was returned home. There are a number of patients who might be seen by the community intervention team on a once-off basis, but if we're looking at those with chronic disease, patients might need to be seen by the CI team on a number of occasions. This is an older case study, but I thought it well described the service around somebody with different needs. So this is a man who was cared for by the CIT team on Dublin North Side. 70-year-old man with a 10-year history of COPD, and at this time he was now having more hospitalisation, more admissions, requiring IV antibiotics, and then referred to the CIT so that they could treat him at home. So in March 2011, he expressed a wish that as much of his care as possible would be delivered at home. So a care plan was agreed between this man, his family, his respiratory team and the CIT team, and then shared with the GP and public health nurse. So it was agreed that he would still need to attend the ED for diagnostics and until his care stabilised, but then as early as possible the CIT team would take over his care and he'd be able to have the care at home. So in 2011 he had 6 referrals from the ED, and in each occasion he was able to come home within 24 hours and he was seen at home for his IVs. There were 3 further referrals from the GP or from the PHN, and there were typically there was an out-of-hours requirement that his condition had deteriorated and that he needed extra nursing or carer support. And the man himself made 5 self-referrals, the most of which were at weekends. In one case, his nebulizer was broken, needing urgent replacement, and on the other 4 occasions he felt unwell and didn't know whether he needed to go to the ED, so he called the CIT team and the nurse carried out a respiratory assessment. On one occasion he did require transfer to the ED, and on the other 3 occasions the CIT nurse contacted the on-call GP. He was reviewed and he was started on oral antibiotics, steroids, and the CIT nurse visited him daily until his condition stabilised. So looking towards the end of that year, he was continuing to deteriorate, and the CIT nurse linked with the GP. A referral was made to the community palliative care team, and also with the PHN. They applied for a home care package and hospital bed. And a care plan was put in place as he was reaching that terminal stage of his illness, which again was a collaboration between a number of people who were involved in his care. On the first piece, I suppose it's looking at as regards an integrated service or a patient level service, which is at that patient level, and it's looking at care coordination. But what you also need is, and I want to give an example of a protocol and care pathway, so that it's actually a standard approach to care as well. So this is an example from the respiratory assessment unit in St James's, and a service that they provide is COPD outreach. And this was the protocol between themselves and the CIT team on Dublin Southside. So they were one of the first outreach services in the country, and subsequently the clinical care programmes with this model outreach services have been rolled out to further areas. So again, what they're looking to do is that somebody who's got an uncomplicated exacerbation of COPD to support an early discharge. The team work Monday to Friday. The patient would be seen for approximately 3 days at home. So if they're identifying somebody as suitable for referral and it's later in the week, they can link with the community intervention team as regards the CIT nurse assessing the patient at home over the weekend and then transferring back the care on the Monday. And the details here of the criteria for referral, the discharge planning, the referral and communication process. So in relation to the referral being made, and also the transfer back of care on the after the weekend, details what happens at a home visit. If something happens and that the patient requires readmission to hospital, and then the other aspects of it as well. So in summary, it's a nurse-led service. It's available from 8 a.m. to 10 p.m. 7 days a week. And it's a rapid response, and a large number of patients would be seen on a same-day basis, and that the CIT team might be that first point of contact. Flexible service designed around the patient's needs, but supported with communication networks and care pathways. So it's great. Thank you.
Thanks, Noreen. In a past life, I had the very good fortune of working in an area that had a very well-developed CIT, and certainly the feedback was always about keeping people at home in terms of trying to have people getting appropriate care in the appropriate environment for as long as possible, and certainly it was a very positive experience from my perspective. Our next speaker is Dr. Sheila McHugh. Dr. McHugh is a research fellow at the Department of Epidemiology and Public Health in University College Cork. And Dr. McHugh is going to talk to us about challenges to the implementation of a national model of integrated care for diabetes in Ireland. So I'd like you to welcome Dr. McHugh now. Thank you.
Hi everyone, thank you very much for the opportunity to speak to you today about some work that we're conducting in Cork in collaboration with the National Clinical Care Programme, looking at the implementation of the national model of integrated care for diabetes. So for the past number of decades, integrated diabetes care has been the recommended model for diabetes management, following on from international policy and practice to reorientate chronic disease management from the acute setting to the primary care setting. And really, I suppose diabetes is the perfect model for integrated chronic disease, given the increasing prevalence and the serious and long-term complications that can arise when the disease isn't managed appropriately. Although the treatment of diabetes is well established, the management of the condition is complicated by the multiple systems in the body that's involved, and then ultimately the multiple healthcare professionals and health settings that are involved in managing the condition. So diabetes care in Ireland in the past has been characterised by a substantial variation, ranging from ad hoc opportunistic management to more structured care characterised by regular recall and review and increasing nurse coordination. And we've carried out a number of studies in this area looking at the quality of diabetes care in Ireland. I suppose in 2008, when we conducted a GP survey, we found that some of the features of structured management weren't evidenced in general practice. There was limited use of patient registries, guidelines and routine recall, and very few practices had any formal shared protocol or had ever had a joint meeting with their hospital team. We followed this up with qualitative work in 2010 to find out what were the barriers and enablers to more integrated care for diabetes patients, and we found that while the hospital service was an essential support for primary care management of diabetes, the lack of coordination between the settings and healthcare professionals led to uncertainty around the boundaries of responsibility and avoidable duplication. Further work conducted in the hospital setting found that there was a similar variation in the management of patients. While endocrinology-led services had more subspecialty clinics and access to allied healthcare professionals, the waiting times for these services were longer and discharge rates to primary care were lower than non-specialty-led services. Moving towards more structured care, there are a number of existing initiatives in Ireland, these bottom-up approaches that we've been hearing about this morning, that have sought to try and improve care in their areas. And of those that have been evaluated, the quality of care provided in these areas is similar to what's achieved in the UK. So this is just a map of some of the different initiatives that are in existence in Ireland and have been for the past 20 years, some of them. And they range from structured care arrangements to more structured care, shared care arrangements to structured care led by GPs, and then some of them are more hospital-based models. And they differ subtly in the integrated care strategies that they employ. Some involve patient registration, audit, feedback, the use of protocols, remuneration and different referral pathways. So given this context of variation, it's not surprising that integrated care became one of the pillars for the National Clinical Care Programme for Diabetes. And part of this national model of care was defined patient pathways for the management of type 1 and type 2 diabetes. So type 1 diabetes and other complex forms of the disease would be managed in hospital centres, while uncomplicated type 2 diabetes would be managed in primary care. And then more complicated type 2 diabetes patients would be managed in both primary and secondary care settings. There was an expectation that this model of care would be remunerated and supported by the appointment of integrated diabetes care nurses to facilitate the integration between both settings, and that these would have a joint role in the community and the hospital. Just having established, I suppose, what the level of care has been in Ireland and some of the evidence that we have on how to improve it, the implementation of integrated care has taken place in, I suppose, a very changeable context. So when we were looking at the integration or the implementation of the national model of integrated care, we were doing it in the context of cuts to the health service, industrial relations issues around the GP contract, and the withdrawal of the ICP from the clinical care programme. So all of these things are happening in the background, complicating the situation for implementation of any recommendations. And I suppose giving a concrete example of something that was mentioned earlier by a member of the audience, that the national model of integrated care has been drafted and a huge amount of work went into reaching that point but never released into the system. So that's some of the context to be aware of when looking at implementation. So our role has been to examine the implementation of the national model of integrated care and identify some of the barriers and enablers to implementation. And we're conducting this work as part of a wider evaluation of the implementation of the clinical care programme in an effort to provide formative feedback to the programme as it progresses. We conducted a qualitative study with national level stakeholders who were involved in programme development. We looked back as far as 2010. Our participants were current and former members of the National Working Group, and 19 people took part in interviews overall. These were semi-structured interviews which were completed in January of this year, and we supplemented this with documentary analysis of existing documents on models of care, policy documents, meeting minutes and media coverage. So some of our findings. Our participants were very clear to stress that some implementation of the national model of integrated care has taken place, largely relating to the employment of the integrated care nurses. However, the challenges arose because these nurses were intended as part of a wider package of integrated care that has never been fully resourced. I suppose it really highlights the vulnerability of implementation to wider organisational factors, such as issues around the GP contract and the remuneration for GPs that stem wider than diabetes care. So the first implementation challenge that we identified in our analysis was the varied uptake of integrated care nurse resources by practices. And really engagement with the integrated care nurses depends on the area that they're working in and the GPs in that area. And that was a sentiment echoed by many of our participants. So in some places, the resource has been welcomed with open arms. Some of the factors that have influenced this reaction have been current access to specialist input or distance from hospitals, practices with large numbers of patients, and also areas where there have been pre-existing initiatives with engaged and interested GPs that have been ready to engage with this new resource. In contrast, in other areas, the resource has not been welcomed as openly. Some of the complicating factors are that in some areas access to the nurse is limited to practice that are already enrolled in some of these initiatives, but ultimately the main barrier that came up over and over again in our interviews was the lack of wider remuneration to support integrated care. So as Dr. O'Reilly mentioned earlier this morning, it's about the alignment of the financial leverage to support the implementation of integrated care in a systematic way. And one participant felt that we had tried all the goodwill bottom-up approaches to integrated care and now we needed more of the top-down approach. The second challenge to implementation that was identified in our analysis was fidelity with the intended model of care. Fidelity is one of the main implementation outcomes that people will be interested in. Really, it refers to, are we implementing as we intended to implement? So there were a number of key roles that the integrated care nurse was intended to carry out that were articulated by participants in our study. First and foremost, to provide specialist clinical input to patients with complex needs and to provide support to the GP and practice nurse in the management of routine patients, largely through training and education. Another key role was to smooth the interface with the hospital to provide facilitated access to even greater specialist input for those patients that required it. However, in the absence of buy-in from primary care and also in the absence of a released model of care to follow, the nurses have had to take a very pragmatic approach to implementation, really working with the situation that they find themselves in, as this quote here illustrates. So in some cases, it's how much they're allowed to do, whether or not they're allowed in the door, and it really varies from area to area. So in some areas, they're involved in education, while in others, they're straight into clinical work, as was intended by the National Model of Care. While existing initiatives enabled uptake among engaged GPs, it has complicated the implementation of the model of care as intended, because they all have slightly different models of care. And while they're not a million miles away, as one participant commented, from the National Model of Care, they're not the National Model of Care. And so the resources are really being adopted or adapted to what's already in place. So that further complicates fidelity to the intended model. The third challenge that we identified is that really integrated care is the foundation stone for most of the recommendations within the National Clinical Care Programme. So it's not just about the links between the GP and the specialists, it's also about the links with other allied healthcare professionals and patients who are involved in this disease, the management of this disease. So for example, the National Foot Care Programme, which has risk stratified patient pathways for the management of foot disease, really the first three levels of that pathway rely on buy-in from primary care personnel. And most participants commented that for the other recommendations to be fully implemented and fully realised, that integrated care had to be in place. So some of you may be wondering whether the cycle of care will address all of the implementation issues that I have just outlined. Our interviews took place in the context of ongoing negotiations around the contract, and just last week the cycle of care was launched, which changes the context of implementation again. The cycle of care is available to medical card holders and those who have a GP visit card, and it entitles the holder to 2 visits with their GP for a structured review, so an annual visit and then a follow-up visit. And following standard processes of care, the GPs will be remunerated for registering patients and for each of these consultations. So will this facilitate greater implementation? Well, we may expect that it would increase engagement with integrated care nurses on the ground among GPs who so far haven't engaged, but then this will probably have a knock-on effect of needing increasing investment in integrated care nurse support. Will it increase implementation fidelity? Well, the cycle of care is not the national model of integrated care, and while it's to be welcomed for those patients who can avail of it, there's potential for it to introduce even greater inequity into the service because it's not available to all patients with diabetes. So the next phase of our research is to look at the impact of these recent changes using 4 case studies across 4 implementation regions in Ireland. And really we want to look at how has the model of care been adapted locally and why, and to look at how it's been accepted. So we are going to conduct interviews with healthcare professionals and people with diabetes to assess the impact of the National Clinical Care Programme on their day-to-day disease management. We're going to use activity data, and also we're currently conducting a national survey of diabetes nurse specialists in Ireland. As well as having this type of fidelity data or data on the implementation of integrated care, you also need data on quality assurance and outcomes to fully assess the impact of integrated care. And there should be supportive feedback mechanisms in place so that the information that we provide is accessible at actionable levels and used ultimately to make decisions, that it doesn't rest on the pages of academic journals. And one of the core elements of integrated diabetes care in Germany was that healthcare professionals collectively discussed data on quality of care at healthcare professionals from all the different levels of the health system. And really the evaluators felt that this was one of the core elements of success of this programme because it helped to break down barriers between settings, but it also established a self-supporting system to increase the quality of care, leading the evaluators to conclude that only integrated care structures that included a quality management system were sufficient to ensure that the improvements that we expect from integrated care in terms of improving quality, access and cost are observable and not just assumed. So I just want to acknowledge the other researchers that are involved in this piece of work with me in the Department of Epidemiology in Cork, and also to acknowledge the openness of the National Clinical Care Programme for Diabetes, who we work with very closely with on this evaluation. So thank you.
Thank you, Sheena. I think it's an interesting initiative when you look at how many, services have people doing very good work all over the place and coming up with good ideas and driving good ideas, and then when you take stock of where everything's at and people have started from different points, the challenges of trying to bring a single pathway into play can be quite tricky at times. Our next speaker is Terry Hannon, and Terry has worked in a number of clinical and managerial roles in cancer services in Ireland. She's here today as the Nursing Development Coordinator for the National Cancer Control Programme, and Terry's going to talk to us about a success story in cancer care where integrated people-centred care is a reality. So thanks very much, and if you could just welcome Terry. Thank you.
Thank you very much. I'm delighted to have the opportunity to talk to you today about our community oncology nursing programme on behalf of the team. Just to put it into context, in Ireland 30,000 new invasive cancers are diagnosed annually. According to the National Cancer Registry in Ireland, this number is due to increase to 40,000 by the year 2020. This is mainly due to our ageing population. There are a number of new technologies and new treatments, which means that many people are surviving beyond their cancer experience. However, this leads to increased demand in the services. Traditionally, medical oncology care is delivered in oncology day ward facilities in hospitals, and this is proving challenging as many of the 26 units around the country were never designed to deliver care to such a volume of patients. So we need to look creatively as to how we will manage our patient population down the line. We have strategic direction in that we have a 2006 cancer strategy which highlighted the requirement to look more creatively at using primary care to deliver cancer control. We also have a cancer nursing strategy which encouraged us and recommended that we would look at increasing capability and capacity for nurses to deliver care more creatively. So this is where the community oncology nursing programme came to be. The aim of this programme is to enable community nurses to safely deliver aspects of medical oncology care to patients in their home, which in turn would reduce hospital attendances to medical oncology day ward facilities. Following training, the interventions would include head-to-toe patient assessment, particularly pertaining to patients' oncology treatments and treatment-related side effects, medication management, disconnection of chemotherapy infusions, and central venous access device care and management. We thought it was critical from the outset, because this is such a complex initiative, that the governance structure had to be right. So for this reason, the national governance of this programme lies with the National Cancer Control Programme and the National Nursing Services, the HSC or ONMSD. They are responsible for overseeing the development, implementation and evaluation of this programme. A steering group was established with key personnel from clinical areas, researchers and educationalists, and they oversaw the development from the outset. Local implementation groups were established where the programme was commenced, and they were vital in relation to having local buy-in. So there was representatives on this group from both the hospital setting, the community setting, and from the Centres for Nursing and Midwifery Education. And they were responsible for ensuring that the standard operating procedures, the communication pathways, the delivery of the education programme and the logistics were in order. What is the programme? Well, it involves 6 units of learning. There are learning objectives for each unit. It's over a 6-month period. It's delivered in the Centres for Nursing and Midwifery Education, and it is both theoretical and skills-based programme. When we looked at the policies and procedures that really assisted decision-making in the oncology day wards, what we found was that there were quite a cumbersome amount of literature to support practice. So for this reason, we developed our community oncology resource book. And the resource book is divided into 2 sections. Section A illustrates really the governance, the scope, the roles and responsibilities of people involved in the programme. And Section B highlights the interventions that nurses carry out in the community. It's illustrated and it's colour coded, so it highlights all the treatment related side effects and indicates to nurses the actions that they should take in relation to managing potential oncology side effects. We thought it was really important to evaluate the pilot programme which was undertaken in Donegal. The methodology for this robust evaluation had both quantitative and qualitative components. The quantitative elements looked at data before and after the programme had been introduced. The qualitative components focused on 4 areas: the impact on the patient, the impact on the community, the impact on the medical oncology day ward facilities, and the appropriateness of training. The qualitative data was achieved through focus groups and patient interviews. Just to give you a flavour of the evaluation and what we found, from a patient perspective, our priority was to ensure that care was delivered safely to this patient population in the community, and we were very pleased to see that there were no adverse effects. The predominant finding was that there was improved quality of life for patients and a reduced burden of travel. And if you look at Donegal, and many of you may be familiar with the hills of Donegal, there's quite a substantial distance for these patients to travel. Some of them would have travelled 60 kilometres to the oncology day ward facility for a procedure that would take 15 minutes and then have to travel again another 60 kilometres home. But I think a lot of these quotes say it better than I can say it. One patient said, "It saved me a journey of an hour and a half when I wasn't feeling well at all. I was at ease with the nurse in my own home. The nurse came most days at the same time. I had the rest of the day to myself to rest. The nurses in the hospital are great, but there's a lot of hustle and bustle." A third patient said, "I could ask questions about things that didn't sink in the hospital, and I could take my time." From a community nursing perspective, what the community nurses felt was it had enhanced their knowledge, skills and competence. So instead of just doing a task like giving an injection or disconnecting a line, I do a full patient assessment from head to toe. I'm more confident now and know what to do when I come across something. Another nurse said that having a direct line to the unit, we have a great relationship with them. We can pick up the phone to them and we feel really supported. It was also said that you have to rearrange your work to suit the oncology patient to factor in chemotherapy schedules. So there are times when you have to rearrange visits, for example, childcare checks. This probably was more difficult than we'd anticipated. The quantitative element, we had great aspirations initially, but what we found was there was no electronic data available in the hospital setting. So what we had to do was we had to go back to 2012 before the programme commenced, and we had to manually extract specific records of interventions in diaries for that period of time and do the exact same for 2 years later. So it was a lot more challenging than we had anticipated. We did, however, find that there was a 69% decrease in a number of interventions from one period of time to the other because of the introduction of this programme. The evaluation, following the evaluation, the curriculum document was reviewed. The programme was accredited was accredited at a higher level, at a level 9, and there was an agreement, a consensus that this programme would be rolled out nationally. So we went from Donegal to Galway, where the next programme was run, and this indicates really the level of demand. The nurses completed the programme in 2011, and in 2012, 204 referrals were received for interventions in the community, and that, as you can see, has doubled, more than doubled in 2014, where there are 449 interventions carried out by community nurses. And I suppose the important thing about this slide is to highlight that those interventions would be normally carried out in the hospital setting, so it was saving that, freeing up those spaces for the oncology day wards. More recently, the programme has been delivered in St James's Hospital, and 8 community intervention team nurses who are working in Rathmines completed the programme. They would, prior to doing the programme, they would have completed some oncology tasks in the community. But what we found in a very short period of time was there was a 41% increase in oncology activity following completion of this programme by these nurses. And really they would accredit that to having more knowledge, competence and skill having completed the programme. So this initiative required change, and it was change for patients in that they had, now their care was being delivered at home instead of in the hospital setting. It meant it was change for nurses in the hospital setting because they were now handing over the care to their colleagues in the community. And for community nurses, it meant taking on additional roles, and it also meant juggling some of their workload to facilitate that. The critical success factors of this programme were that the patient remained front and centre throughout the process. There was a willingness to share knowledge and experience from the hospital staff, oncology staff, to the community. There was a mutual respect, and there was a really clear understanding of each other's roles that some of the public health nurses said they wouldn't have appreciated exactly what was happening in the hospital, and similarly the hospital staff wouldn't have appreciated the roles of public health nurses in the community. There was a support system in place that worked. We identified and managed risk. There was a willingness to change despite the fact that there were no additional resources for this programme. People really were very passionate about it and wanted it to work. There was an excellent governance structure in place. Our emphasis was on doing it right as opposed to doing it quickly and doing it safely. And there was a consensus among all stakeholders to measure and evaluate on an ongoing basis to make it better. So in conclusion, safe integrated healthcare requires vision, leadership and active change management. You need more than passionate personnel working for the greater good of the public and patients. You need to have policies, systems and processes in place. You also need to have organisational and management support. This model we think has worked, it is a success, and it could be adapted for other chronic diseases. But it does require further resources for national rollout. There's no success without great effort, and there was a huge amount of people involved in this programme. I would like to specifically acknowledge patients, hospital personnel and community nursing personnel who've supported the programme, my colleagues in the NCCP, ONMSD and CNME. We were very privileged to receive an award for this programme in the UK in 2012 in the Quality and Care Award. And if anyone would like to read further on it, we have a publication in the British Journal of Community Nursing. Thank you very much.
Thank you, Terry. I was interested there, and I think it was your second or third last slide, the critical factors in the middle box. I don't know if it was intentional, was that the patient is front and centre. And I think if we could deliver all our services with that as the core ethos, we could overcome many hurdles. Our next speaker is Dr. Niall Crumlish, and Niall is a consultant psychiatrist and a clinical tutor at St James's Hospital. He has an interest in the physical health of people with mental health problems, and I think just about to put my mental health hat on me for a minute to say that this is an area where we continue to be hugely challenged in terms of improving health outcomes for people with mental health problems. And I think it's a real example of how we need to integrate services. We have people attending mental health services who do not have access to or get sufficient input in terms of their physical health, and their health outcomes are still appallingly poor. So I'm delighted that Dr. Crumlish is here today to talk to us about the feasibility of a physiotherapy and nutritional intervention to reduce cardiometabolic risk and increase fitness levels in people with schizophrenia and bipolar disorder. And just before I hand over to Niall, I just want to apologise because I actually have to leave after this, despite the fact that he's the one person talking about mental health here this afternoon. And I think Anya's going to hand over for the next speaker. So thanks very much. If we could just welcome Niall to the stage. Thank you.
Thanks very much. It's really nice to be here. It's really nice to be asked to speak alongside my colleagues here. I thought that their talks have been really incredible, and kind of inspiring for somebody who's at the stage that this work is, like me, who's my work is at a different stage. A lot of what we've been hearing about is programs that are, integrated care that's established. This is really about something that we're establishing and how to go forward with it. I'm presenting. I want to acknowledge Alice. I've got an acknowledgement slide later, but I want to acknowledge Alice Waugh, who's a senior physiotherapist who's done a huge amount of work on this, and Niamh Murphy, who's in the audience as well. What I'm going to talk about is an initiative that we set up a few years ago and we're continuing to work on, called the Metabolic Clinic, basically, which is a HSC, I'm a consultant psychiatrist in the HSC Dublin South City and based in James's. And the physio department is based in James's. A service that we set up a few years ago, which is cross-disciplinary, and which was, I'm going to talk about what we did, how we evaluated it, what we would like to do with it further, and also why we set up such a service, which is really the top piece there. People with major mental illness die 10 to 15 years younger than everybody else. This is one of the worst statistics for me in life. And is probably not well understood enough. I tend to think of this as not so much a life expectancy at birth, but a life expectancy from the age that you get diagnosed with schizophrenia or bipolar, which is 20, 25 years old. So 10 to 15 years is about a quarter of the life that you have left gone. This is not getting better. If anything, it's getting worse. And the reason why people die so young is predominantly cardiovascular disease. So it's not suicide or any of the other things that you might consider disease-specific death. It is stroke and MIs and so on. The BMJ, Graham Thornycroft and the BMJ in 2013 said that the premature preventable death of thousands of people per year with mental illness was a human rights disgrace, and urged evidence-based interventions to stop this happening, including lifestyle interventions. Preventable premature death. The difference between people with schizophrenia and bipolar and other people is, as much as anything, a disproportionate exposure to risk factors that are modifiable. I'm going to talk about exercise in a second, but other risk factors are things like smoking. So people with schizophrenia smoke more than 3 times as much as everybody else. There's conflicting evidence really about whether antipsychotics can prolong life or don't. Diet tends to be very poor. Just the 0 out of 40 there is a cross-sectional study that we did a few months ago in James's of stable outpatients with schizophrenia, and we found that nobody of those 40 was eating enough fruit and veg, which is your 5 a day. So now actually the general population in Ireland typically doesn't eat 5 a day anyway, but the general population eats about 3 or 4 pieces of fruit and veg a day, whereas we found a mean of 1. We also know that people with mental illness get inequitable access to medical care, and that's for probably 2 reasons at least, which is that people are less likely to seek care, and when they do seek it, they're less likely to get adequate care, less likely to be adequately investigated, and so on. Another modifiable risk factor is exercise, and I'm going to talk about sedentary behaviour as one part of exercise. Sedentary behaviour is basically sitting. That's really it. People in the West, people in Ireland, we sit way too much anyway. I think more and more people know this. We tend to spend about half our time or a bit more of our waking time sitting. The evidence is that people with serious mental illness spend even much more than that, again, up to 80% of their time sitting. And that this, just sitting, is a risk factor for cardiovascular disease mediated through metabolic syndrome. So sedentary time, the more time you spend sedentary is strongly associated with the development of metabolic syndrome, and that's including in people with major mental illness. So that's been specifically looked at. Sedentary time or sitting is amenable to change. Essentially, the more you sit, the more likely you are to develop metabolic syndrome, and the more likely you are to develop metabolic syndrome, the more likely you are to have an adverse cardiovascular outcome, including cardiovascular death. Now, so a few years ago, I began to get worried about metabolic health and cardiovascular risk in my patients and the patients of my colleagues in the HSE Dublin South City service. So I set up along with colleagues in clinical psychology, nutrition and physio, this thing called the metabolic clinic. So initially what we did, just to tell you how it's evolved, initially we set up a 6-week group program in which the physiotherapy intervention, physiotherapy has always kind of been front and centre here and has really run with it and probably led on it and been the most active participant in it. And physio at the beginning ran a 6-week supervised exercise program. So they would take a group of our patients to the gym and run an exercise program there and do that every week for 6 weeks. At least in theory, that's what happened. What actually happened was that people tended not to go. The acceptability of this particular approach wasn't very good, and similarly with the nutrition input and other pieces. I should say that this is in the context of what is a very limited physiotherapy and clinical nutrition service to mental health patients within the James's service. We're administratively different, so we're not really the hospital, and we don't have really any access. We some sort of goodwill access to physiotherapy and clinical nutrition, but very limited. We also didn't evaluate this, so we decided we should, and we in 2013 and through last year and even into this year, really, we changed the service, changed the intervention a bit, and we introduced some pre and post evaluation into it. We had metabolic syndrome as our key marker of cardiovascular risk, and we measured that before and after a slightly changed intervention. This was none of this was funded, and this was all done in, I heard Sheena use the word goodwill earlier, and this was all done in goodwill time. basically our own time. What we wanted to do then was to recruit people from our HSE clinics, adults. We did a number of assessments which were metabolic parameters of metabolic syndrome. The actigraph is an accelerometer which just gives you a measure of sedentary behavior, low intensity activity, high intensity activity, and so on. And we also looked at fitness using a thing whose name has gone from my head right now, but we also measured aerobic fitness, and aerobic fitness was pretty poor. The intervention was, we changed the physiotherapy intervention from being a group to one-on-one, and that was a key change. There was 8 weeks, we extended the number of weeks to 8 of individual physiotherapy sessions. Rather than it being supervised exercise, we changed it to coaching, so that it was a motivational interviewing type approach, and week on week, Alice would meet each individual in the group and look at their goals for that week, exercise-wise, look at their barriers to exercising that week, and so on, and work with them on really a more sustainable approach to exercise, I suppose, rather than in retrospect supervised exercise every week. So goal setting and review. We also, as this was happening, we were also running or trying to run group clinical nutrition sessions, but actually the acceptability of those remained poor. So to be honest, effectively this became a physiotherapy intervention. And what we found, and this is, this is a feasibility study, so what we found was that the results actually were probably better than I expected that they would be. So we found that there was 26 people were referred. We sort of had to stop accepting referrals then because we didn't have the time to see everybody. 16 people entered the study and 13 completed the one-on-one individual sessions with physio. And out of those people, 8 people achieved a reduction in cardiometabolic risk. That is, that they had fewer metabolic risk factors for cardiovascular disease at the end of the 8 weeks than they had at the beginning. I hadn't really expected this, because these were fairly hard outcomes. We selected them as fairly hard outcomes, and I wasn't sure how amenable to change they would be over a relatively short period like that. We also found that 4 people who had metabolic syndrome at the beginning, which is 3 out of 5 metabolic risk factors, that they did not have metabolic syndrome at the end. I should say that we did 3-month follow-up for a few of these people, but not enough to really be able to report it properly, but it looked like people sustained the benefits that they gained in the 8 weeks. There was some people lost status, and some people stayed the same, and some people got a bit better. Again, noting the numbers, you have to be cautious about p-values and everything, but it did look to us like there was a relationship between doing better metabolically and spending less time sitting. So what we learned from this feasibility study, we learned that compliance was good in a population that's generally considered difficult to retain. A big thing was that we learned that individual work is much more acceptable for this population than group work. There was less time in sedentary behaviour, and we were encouraged by this preliminary data. I suppose another thing that we learned is, having put a lot of time into this, we learned that to take this any further, we probably can't continue to do it in goodwill time, and that's really where we are right now. So how do we build on it? From last year, we developed the intervention somewhat. We've developed it a bit more. We have been looking for how to progress this, how to fund further intervention and evaluation of this, including HRB proposal, which we were shortlisted but didn't get. Within that HRB proposal, one of the reasons I mention it is because we did change what we were offering. We expanded it out to James's and Tala, which is a big catchment population. We extended the intervention in that proposal to 12 weeks. We've a clearer focus that Cozy Keatle, is a person who's very interested in sedentary behaviour, and so our focus is on reducing sedentary time with a view to that having an impact on metabolic syndrome. What we want to do is baseline, post-intervention, and 3-month assessments. We think it's very important to do 3-month assessments to see that we're looking at sustainable change here. And our feeling is that will require, at this stage, a clinical specialist physiotherapist, and we're currently looking for how to establish such a post. And my feeling is that it'll take about 3 years to introduce, develop and evaluate this service for a substantial number of people. That's really the role of a clinical specialist. I suppose the key thing there is, although this isn't a research, we're not looking at a research proposal now, we're looking for a clinical intervention. It is important to accumulate evidence. That's what they said in the BMJ. We all believe this. My feeling is there's no value in developing a new role like this without continuing to assess whether it's effective, and doing that with hard outcomes like metabolic risk. I've mentioned potential for regional and national role. I suppose, again, the context is that although there's no such thing as a mental health physiotherapist in Ireland, these are roles that are being established in other countries. And there is indeed an association of mental health physiotherapy now. It does seem like a fairly obvious, to me anyway, a fairly obvious development. And the barriers to establishing this is really at the moment just funding. I've listed a few there, including governance. Governance is always an issue. We're talking about a relationship between the HSE, which is one organisation, and James's, which is a different organisation. And there's no clear governance structure right now for James's physiotherapy to work within the HSE or with HSE patients, but we would imagine that well, actually, even since I put these slides together, we're having conversations about that and how we might do that, and that doesn't look like it's a barrier. So the barriers are there's no culture in Ireland of physiotherapy within mental health, for one thing. And that's probably a barrier on either side. Certainly within my service, and within every service, there's competition within a budget, and if you're looking for an OT or a nurse or a physiotherapist, there's always competition. There we go. That's basically how we would see it working, the evaluation, ongoing evaluation. Again, we started working on this before thinking about it according to principles of integrated care, but we think it does tick some of these boxes. We think we've identified a need. We think that need isn't met within current structures, and we think that it could be met with a cross-disciplinary, cross-organisational approach from the hospital to the community. I suppose one of the other principles of integrated care with respect to chronic disease is managing things at the lowest level of complexity, and we are really talking about managing metabolic risk of cardiovascular disease using a very low complexity intervention, which is essentially asking people to sit down less than they do. And that's my colleagues. Thank you.
Thank you very much, Niall. I know that both from Anne's perspective and our own, that the whole issue of mental illness and physical issues we need to look at. We can't keep separating the mind and the body forever. I have the great privilege now of introducing Mary Flanagan. Mary is the Director of Nursing for Older Persons in Dublin North City and St Mary's Hospital and Claremont Residential and Community Services. And Mary is going to tell us about clinical case management and its role in the continuum of integrated care. Thank you, Mary.
You've probably been sedentary for the last 60 minutes or so hopefully it won't stay for too long. Thank you, Anya, for the introduction, and I suppose before I start, I also want to acknowledge the work of my colleagues in Dublin North City, but also acknowledge that I've borrowed some slides from Dr. Siobhan Kennelly's work, but also from Elaine Dunn, who was the first clinical case manager in older persons. I suppose just to say, I don't really make apologies, and I know there was some discussions this morning around, the integrated care model, and I suppose the usurping of it in some respects around chronic disease in older persons, but I suppose we also know from the evidence that integrated care delivers the greatest benefits to older people. So in some respects it is the reason why we have to do what we do. So for the next 10 minutes or so, I want to talk about the background to the post, what case management is looking like, our progress to date, how it works in practice, and I suppose some conclusions. I suppose I start with the background, and some of you may remember as far back as 2001, the National Council for Older People in Ireland talked about case management and its role in supporting older people to stay at home. But in 2012, we were, I suppose, again looking at what were we going to do differently in Dublin North City around managing the complexity of care for older people. And I suppose we were one of the speakers this morning talked about a coalescing of forces, and I suppose the coalescing of forces was probably the SDU were maybe coalescing us, and we were the forces that had to try and deliver and look at how we might do something a bit differently. We were also, I suppose, working at that time very much as an integrated team, and by that I mean our ISA structure, and Anne at the time was actually our ISA manager, but also with the acute hospitals. So we were working together in a way to see what could we do that we were doing different that would make a difference. And also, I suppose, we were very much influenced by our colleagues in psychiatry of old age, who, in many respects, the community psychiatric nurse model was working very much in primary care, but also interfacing with the acutes. So in many respects, the start of this happened as far back in 2012. But I suppose we wanted to understand the patient journey. And I suppose for many of us at the time, the patient journey for our older persons was that episodic care that was ending up via the ambulance, and I suppose we can call it the magic roundabout, but we could also call it the merry-go roundabout. And I suppose in many ways, when you get onto that roundabout, you actually don't know what pathway you're going. So for any older person, you get in the ambulance and you actually don't know. And we had discussion this morning about if we keep doing the same thing, we're going to keep getting the same results. But we know if we keep presenting, our older people keep presenting at the ED department, we know that twice as many of them are admitted in the first instance, and that their lengths of stay. So there's nothing new in this. We know this. So we've got to change. We've got to change that journey. We've also got to change a little bit around, I suppose, our thinking processes, because we've got a lot of elderly people who actually don't want to go to hospital. That's the first thing. They want their care to be delivered at home, but they're also frightened because they don't know what the outcome is. So there are a lot of challenges for us. So we looked at, I suppose, using case management as a strategy to look at complete that loop or network of services for our predefined population of patients. So we looked very much at our older persons within Dublin North City. And I suppose it's looking at it, working across our formal hierarchies, but also, I suppose, producing in many respects a matrix of services. And I know this morning there were a lot of diagrams looking at, the whole different organisational structures, and there's no point in saying otherwise. There are challenges in working within those different organisational structures. But I suppose if you keep the vision and if you keep the person and the patient at the centre of that, you will break down some of those structures. But I suppose we also have to recognise that the care coordination is longitudinal. Our older population are working across a number of services. They're interfacing with a number of services. But they're also a point, we know our population is ageing. We know our older adults, there are more of them around. So we know that there's a longitudinal spell of care that they're going to need. And I suppose we have to be prepared to see how we're going to manage that. So I suppose in many respects it's about a systematic approach to care, and I suppose it's navigating the clinical and the social support networks that are needed for those with complex care needs. But I suppose it's about providing a quality care across that continuum, decreasing fragmentation, which in it is a challenge across many settings, but also enhancing the quality of life and supporting value for money. And we know that we're doing that, because I was talking to one of the case managers yesterday, and she was giving me an example of somebody that she has on her books, an elderly lady who's presented 3 times to A&E. So part of what the case manager's role is targeting what we call the frequent flyers. This lady has been A&E in 3 times, and it's no surprise to you. On all occasions, she's had her bloods done, she's had some abdominal x-rays done, and lo and behold, the last time she had an ultrasound scan done. But in actual fact, what this woman needs is actually social supports. She pitched up at A&E last week. The case manager has her client list is already identified in A&E, knows that if this lady called the case manager. So she got onto A&E and said, actually, you know what, she's already been with you 3 times. If you look at the records, you don't need to do A, B and C, but if we divert her to an alternative service, which she managed to do, we will manage her care, we will get her home again, and we will look at what social structural supports we need to put in place to keep her at home, but also to allay some of the anxieties that she has that is causing her, and she's actually ringing the ambulance herself. So I suppose it's about doing things differently, and it's about bridging the gap. And I suppose we know what our older people want is they want person-centred coordinated care, but they also need advocates to do that, because perhaps they're not as well and able to do that as you and I may be. So I suppose it helps to maintain their health and their independence. So if we look at the continuum of care, and I suppose when the case manager is about linking home, community and hospital, or linking hospital, community and home. And in some recent work that I did as part of my social care hat, we were looking at some of the acute care environments and looking at, what is the complexity of care that is leading to, I suppose, delayed discharges and leading to people, I suppose, staying in beds for longer than they need to. And one of the things that was very clear to us that I suppose, relationship and that understanding of what is going on in somebody's home is not always captured in the acute environment. So there's a gap in the information sharing and the information giving. So I suppose when we're looking at our case managers, part of what they're doing is making sure those linkages exist and that people are very, very clear about it. So if we look at our older persons, we know that the services are built around the individual, but they're also joined up, and I suppose more importantly that they're proactive in their approach. So if we look at the elements of case management, and I'm sure for many of you, you're very familiar with the Kaiser Permanente model and the Evercare models of case management. But I suppose we're particularly interested in the 4% of the very population, of the population, the level 3, the very high intensity users of unscheduled care. And particularly in the older population, they're going to be the people with the frailty syndromes. So we can actually actively manage those. We do have a role in level 2, which is around coordinating, but it's particularly important that we target those in that higher 4%. So if we looked at what do we want to see in a service design for older people going forward, we want to see comprehensive assessment, really important screening, and that's where the case managers come in, screening people, but also providing clear interdisciplinary plans of care that can be, I suppose, manage expectations, but also that we have clear outcomes. Because for our older population, if we're not doing, we talk a lot about advanced care planning, but we also need to talk about anticipatory care planning, because we know those with frailty syndromes, there is no secret in where the outcomes of their care is going to end up if we don't manage it. And if we don't work with their families and their caregivers in terms of managing expectation and being very clear about that, we're not really going to be doing them a service. And indeed, they're going to be an increasing demand on our services where we can actually manage them at home much more effectively and coordinate their care, I suppose, utilising very available resources, utilising services like our step-up beds, our community response beds, our respite services, or our day services. So looking at what the clinical programme is looking at is looking at the older person, and instead of us maybe having pathways off, having that cycle and having a very clear system that is easily navigated, but there's flexible networks of care where I suppose from beginning to end, but also connecting and combining services, so that when an older person interfaces with one service, that it actually connects with another and combines, and that information, which is the critical thing, is shared across the services. So I suppose our progress to date, we've got 4 community-based posts in Dublin North, working very closely in collaboration with our community geriatricians and many others. None of this would be possible without the community geriatricians taking the clinical lead and the clinical governance and supporting this. I suppose I'm in an unusual position in that I have access to a number of services, that I look after a number of services. So in many respects, I am in a position that I can enable the case managers to do their work maybe in a different way. We are and have developed a number of enhanced ambulatory care pathways for older people to support admission avoidance, and including end of life. And that is so important that we get that advanced care planning when we're dealing with our clients with dementia and indeed other chronic diseases, that we have good advanced care planning in place, and we can allow our older people to die at home where they want to, with the right supports and the right structures in place for that to happen. I think the role has facilitated real integration across traditional acute and community boundaries. And our clinical case manager in Dublin North is actively working on the development of the community virtual ward with her consultant geriatrician colleagues in Beaumont. But I suppose that does, in many respects, require what we would describe as a paradigm shift. It requires people to trust us in the community, to do things differently, to be able to deliver that complexity of care. But it also allows us to be able to do things like look at predictive risk of readmission from the hospital, from the community back into the hospital. So we can actually, I suppose, again, get involved in making sure that we are diverting people to the right place. The other thing is, I suppose, it has created new nursing roles, and while that might be in many respects a challenge in our current environment, but it also means that your nurses, the clinical case managers are nurses, and they are not only are they advocates for the patients, they're collaborators, they're brokers. They have to broker deals with managers of services for older people, broker deals with community geriatricians, they have to broker deals with GPs, palliative care teams, but they also, I suppose, have to work very strongly at collaborating and coordinating what they do. So I suppose, if we just take, I suppose, this case in point, this is an example from our Connolly community geriatrician and our case manager. Our clinical case managers are community-based, but we've wrapped them around the hospitals, and I suppose that has been important in terms of the communication, picking up people when they present at A&E, picking up people in the day hospital, or indeed picking up people in the community where the GP. So in this case, the clinical case manager got a phone call from the GP, 90-year-old, frail, recent discharge from hospital, multiple comorbidities, not doing well at home, not eating, not drinking, and lots of care, stress and burden. So the comprehensive geriatric assessment at home with the case manager the following morning, working collaboratively with the geriatrician, decision to remain at home with supports, the home care package, community intervention team to come in and give some subcutaneous fluids, a very clear care plan with the anticipatory care plan put in place, respite options discussed with family, and plan for monitoring and following up. So what we know was the number of options were discussed, assessment, query, what are the options that I have available to us, and when we look at the final outcome, we know that doing well at home 6 months later. So I suppose that's where, when you have collaborative working and early intervention and looking at your suite of what's available to you, you can actually make sure that you are keeping people at home and avoid hospital admissions. So I suppose for us, what have the key challenges been? Well, there has been, I suppose, a need to learn collaborative working. There were new posts. I know that for lots of people, they weren't clear about what this model was going to look like. How was it going to interface? I know certainly my CIT team say the more case managers that are coming on board, the more work is increasing. But that's all right, because that means we're doing things right. We are keeping people at home. We're avoiding hospital admissions, and we're promoting early discharge. We have to learn a little bit of interagency work. A need to, I suppose, look at how we coordinate care, how we maybe signpost people, and when we do signpost people, when we're to make sure that they actually get to where we're signposting them, and that when they get there, that people understand why they're there. I suppose one of the things I've talked about here is value placed on high touch versus high tech care, and high touch isn't all. I suppose it's about hands-on care, but it's also hands-off. Making a phone call, checking in, seeing how are things going, is everything all right? And again, that is particularly important when we're dealing with families with people with dementia. Working across our organisation and funding silos, and I know there was some discussion around this morning, but I suppose when we're talking about people at home, we're talking about primary care, but we're also talking about social care. So we've got to look at how well do we make sure those things work together. The challenge of ICT cannot be underestimated. Wouldn't it be ideal if, when somebody pitches up an A&E, the clinical case manager gets an alert to know that they're there, that they can actually begin to put some sort of a plan of care in place. And we are working, I suppose, with ICT to look at how we might begin to develop not only, I suppose, a resource base, but also a navigation hub, an ICT hub that would help us with how we might do this. And the other challenge, and there was a lot of discussion this morning about our outcomes, but we are challenged, I think, to measure, because so much of our focus is on measuring, is on hospital avoidance, but that in itself is difficult to measure in some regards, but also we are measuring our activity and how we measure that within our I suppose, our outcome-based, and also the access to data. I mean, it was interesting this morning how the Scottish speaker was able to look at, you know, how many falls were presenting at A&E, and that's fine, and we can get some of that data, but sometimes we're very protective of that data and it becomes the hospital's data or the community data. So when you actually want to break down and look at and measure the impact that you're making on what you're doing, and you're trying to get someone else's data, that can be a challenge. So I suppose, to conclude, I mean, the developments of the clinical case manager means that you have to have responsive teams in place, so you have to have responsive services as well, and supports. It is about connecting and integrating the services around the client, and I think we can learn together, and the evidence to date speaks for itself. And I kind of like this last slide, because I think it says, you know, instead of calling 999, can we maybe call the case manager? Thank you.
Thank you very much, Mary, and I think the challenges that you've described really echo the challenges that we've heard about throughout the day. So thank you for that. I now have a great pleasure to introduce the judges, who are Dr. Tom O'Connor, and Tom is a lecturer in the Department of Applied Social Studies in Cork Institute of Technology, and Tom has been very interested in the whole area of integrated care in Ireland and has edited a book that was published in 2013, I think. Yeah, really good book, well worth reading. And of course, Dr. Philip Crowley, who is the National Director of Quality Improvement, and who has worked very closely with the clinical programmes, and is also extremely interested in integrated care. And I'll hand you over to them.
Thank you very much, Anya. We haven't had a huge amount of time to consider the presentations. Obviously, they're just finished. But we did look at the outlines beforehand, and we've reviewed all the posters as well. And you know, we have heard a lot today about the challenges that face us, and I don't think you can have a meeting on healthcare without acknowledging the kind of stresses and strains that have been visited upon, the burden, I think, that has been visited upon our frontline staff through the moratorium, which was a very blunt instrument over many years, financial cutbacks, occasional significant care failures that led the service to be in some ways besieged at times. So I think, you know, many health services might have failed under those circumstances, and others in other countries which have had similar cutbacks have not fared, I think, as well as ours. And the reason I think that ours has succeeded in surviving and indeed in many ways thriving, as is evidenced by today's presentations, is because of the professionalism and commitment of everyone here today, of the people who presented, of their colleagues, and everybody out there in the front line. And anytime any of you ever have the, I suppose, misfortune to be a patient, and I have been a number of times recently, I'm completely struck by that. So I think if you needed any convincing of that fact, the 27 posters outside and the 6 presentations that we've just sat and listened to today is crystal clear evidence of the kind of innovation and the kind of new models of care that can develop in times of adversity. And in many ways, I think we've tried to use the downturn and the difficult times to do just that. And I think today's, as I say, presentations demonstrate what we need to do more of, which is we need to continually innovate, change, and develop new models of care. And I'd like to hand you over to Tom, first of all, to present the winner of the poster presentation.
Hello, my name is Tom O'Connor, and we had a very difficult job judging the posters. The posters were all very, very good. There was such a diversity across the posters. There was such an amazing array of interprofessional working collaboration, shared care planning, all the things we were hoping to see in them. And realistically, it was very hard to come to a winner, and I know people say that all the time, but it's actually true today. I will announce the winner for today for the poster. And the winners are Dr. Deirdre Jones and Amanda O'Halloran for plastic surgery day service in Roscommon. The judges were impressed by the wide-ranging community and health care professional integration across various groupings, in particular that horizontal integration which that reflects, the GP information sessions which links community care to primary care and then links back into the hospital care, with the vertical integration then of hospital, primary and community care. The service is up and running, it has a strong patient benefit, it's got shared care planning, and it's also very much person-centred. So please, a warm welcome for Deirdre Jones and Amanda O'Hanlon.
And potentially somewhat more controversially in that you can all judge the presentations, and just two of us have actually done that. We could do a clapometer or something like that to try and assess, but I think it would be quite hard to analyse. So we have gone with the presentation on Community Oncology Nursing Programme, supporting nursing-led oncology provision from Terry Hannon, Louise Mullen, Marie Lafoy, Eve O'Toole, Mary Wynne and Janice Richmond. I think some of the work was in Letterkenny General Hospital. We felt that it was very innovative, very important. I think all the presentations were important. It was a particularly important presentation, I think. It was very much focused on a positive patient experience. It is the way we have to go. So I'd like to congratulate them very much on an excellent presentation. Thank you all very much.
So I'd just like to finish. I don't know about you, but I think between the posters and the platform presentations, I'm just absolutely blown away by all the really fantastic, innovative, integrated care that's happening all around us. And I think that that can very often get lost in the crisis management and in the noise of the system. And I hope that you've enjoyed today as much as I have. I think it's been really interesting to hear the international speakers talking about the challenge of integrated care and the challenge of implementation of what's a good idea and a good design. And I think that we'll all take away some really helpful messages. So I would like to say a few thank yous. I'd like to thank very much the conference organising committee, and in particular I would like to thank Michelle Tate and Anne McMenamin. Really, they have been absolutely fantastic. I'd also like to thank our conference partners, InvestNet and Dublin Castle, and can you give a round of applause, please, to both of those organisations? They've been fantastic. I'd also like to thank all the speakers, the chairs of the sessions, all the panel members, the International Foundation of Integrated Care, our poster presenters, our platform presenters, but most of all, I would like to thank each and every one of you for coming, and I'd like you to leave with the idea that is féidir linn. Thank you.